Welcome, Professor Rochwerg. Welcome to our podcast, and thank you for doing this for us. Professor Rochwerg is Vice Chairperson of Surviving Sepsis Guidelines. So, as we discuss about the sepsis, the first question I would like to know is, are steroids really useful? If yes, then what movement, what time we should be using it?
So interesting, right? Steroids is one of these interventions for sepsis that has changed over the course of time. There's enthusiasm, it sort of goes up and down. We participated in a recent meta-analysis, which was just updated in Critical Care Explorations, incorporating the two biggest trials, Approaches and Adrenal. And although those trials weren't positive per se for the primary outcome, when you look at the totality of the evidence, I'm fairly convinced that there's benefit when it comes to corticosteroids in patients with sepsis. A small reduction in mortality, reduced organ dysfunction, improvement in shock resolution. And so having participated in this and summarized through meta-analysis, I'm much more aggressive with how I use corticosteroids in critically ill patients. I guess then the question becomes is what steroid do I use, at what dose, and for how long? And
Here goes it, and how do we time it? When do we initiate and start using it? I mean, at what moment I think of using steroids in sepsis?
it's a great question. And so I guess for the timing piece, traditional guidance in surviving sepsis has been to wait until your patient is on multiple pressors and you've been volume resuscitated. We did meta-regression as part of the systematic review, and we showed benefit of steroids across a spectrum of illness with sepsis. And so I'll tell you, Bharat, I'm much more aggressive with how I use steroids. Even for patients that are on any dose of corticosteroids, I am initiating any dose of vasopressors, I am initiating corticosteroids. Even for patients with organ dysfunction, with a soft blood pressure, I'm starting steroids in that population, given the results of our review.
Oh, so you don't wait for the vasopressors to come on. The moment you feel there's a need or this patient might need a vasopressor or there's one organ dysfunction, you initiate.
This is more aggressive than most. I acknowledge that. We have a RACE team at our hospital. It's an ICU outreach team. And if I'm seeing a patient with sepsis, with outreach team, with organ dysfunction, and they're considering coming to the ICU, I am initiating steroids. As I said, we did a meta-regression analysis as part of our systematic review, and we saw a consistent relative effect of steroids across a spectrum of illness. And so we'll see what happens with this upcoming Surviving Sepsis update. I'm certainly pushing for more aggressive use of steroids, but based on this analysis, and I think it's data-driven and evidence-based, I use it quite early in folks.
So now we know when to start the steroids. As you said, you've been very aggressive in starting the steroids at a certain point. But what dose you exactly give and what kind of steroid, whether you dexamethasone, hydrocortisone, or methylpred, what exactly? Is there any difference? We use different kind of steroids?
That same meta-analysis that I talked about, Brad, we had 46 trials that have looked at steroids and sepsis and septic shock over the last 60 years. Crazy. So many studies, so many patients.
We don't have an answer.
Well, I tell you is that all of those trials use different steroids. Some use hydrocortisone, some use methylprednisone, some use prednisone. And we did subgroup analysis based on did it matter which steroid. And that benefit that I told you about reduction in mortality, reduction in organ dysfunction, increasing shock reversal was consistent across all of the steroids. We even looked at dose, and we looked at dose in a number of different ways, high dose versus low dose, based on meta-regression, treating dose as a continuous variable, and similarly, the same benefit was seen across doses. So I guess what I'd say to you is that it probably doesn't matter what steroid you use and at what dose. I tend to use hydrocortisone, and I tend to use hydrocortisone, 50 milligrams Q6H, so about 200 milligrams a day. The only reason I pick that is because the majority of the 46 RCTs use that dosing regime, but I can't tell you that that's the magical setup.